as Sherry mentioned, I manage a program in Nigeria that's been working on domestic resource mobilization for TB and for HIV. And I manage another project that's working on increasing case detection through the private sector. And both of these programs have contributed to the presentation that I'm going to give, or discussion I'm going to initiate on TB, social protection, and health insurance. So the Health Finance and Governance project that I work on that's focused on domestic resource mobilization for HIV and for TB works all across the world, but I'm going to focus on Nigeria because it's the example that I think I can use that best highlights what we're talking about here. So our work is focused on a particular state, Lagos State, which is the commercial and economic hub of Nigeria. It's 24 million people strong, so it's practically a country when you look at it in the context of the rest of Africa. And it has significant burden of both TB and HIV. It's urban, it's dense, and it has massive slums in it as well. So the prevalence of TB is about 326 cases per 100,000 population, and the case detection rate is just 14.5%. There's also a significant burden of HIV, as I mentioned, and we estimate about 200,000 people living with HIV, of which only 37% know their status. So that's the disease side. On the financing side, both the TB program and the HIV program are both heavily donor financed. There's a real need to increase domestic resource mobilization in Lagos State, and you can tell from the case finding and from the number of people who know their status at HIV, there's a long way to go to reach any of the goals and targets that the state would like to meet for TB and HIV. At the current time, like many countries in Africa, the state is initiating a state-supported health insurance scheme. So it's called the Lagos State Health Scheme, and a lot of the work that we've been doing is to support the setup of that scheme and also to ensure that TB and HIV are covered by the benefit package that that scheme is going to cover. So, just briefly, social protection. I feel like I should do it because I have the slide, but I think Fatu did a really good job of talking about what social protection is. So in a world filled with risk, social protection systems help individuals and families, especially the poor and vulnerable, cope with crises and shocks, helps them find jobs and have the resources to invest in the health and education of their children, and also protect aging populations. One of the neat things about the health insurance scheme is that it is really being set up to support social protection. It's being focused on the poorest of the poor in the state and the indigent and the aged. And I'm going to talk a little bit more about it. So the health insurance part of the whole thing. Health insurance is one way, in fact, I think it's the only way that Fatu didn't mention just now when she talked about social protection. Health insurance is one way that we can address the health implications or the costs of health and the contribution of ill health to catastrophic costs. And when we talk about health financing, we talk about three things. I'm not going to bore you with too technical definitions, I promise. But the three things are: a health financing system should collect revenue that we can use to run the health system and health sector. It should also ensure pooling. And what do we mean by pooling? Each one of us doesn't know when next we're going to be sick, right? So I don't know when next I'm going to have the flu or have malaria, and neither do you. You can't predict it. And you don't know what you're going to have, how much it's going to cost to treat whatever it is you have. But as a collective group of 10,000, 100,000, we've got incidence information, prevalence information. We can predict how many people are going to fall sick. Maybe not which ones are going to fall sick, but we can predict it. So having that pooling of risk allows us to plan for how many HIV cases or TB cases we'll have in the future. And if we know how much it costs to treat them, then we know how much money it is that we need to set aside. So that's the effect of pooling. The other thing that pooling allows us to do is, if done well, it allows us to cross-subsidize. So if we have people in the pool who are relatively more healthy, relatively less healthy, healthy, relatively wealthier, less wealthy, then the pool allows us to cross-subsidize across those people. And then lastly, there's purchasing. So one person going into a clinic, you don't get to tell the doctor how much you're going to pay. But if there's 10,000 of you who are purchasing health services, you suddenly have some more power, right, through that number, and you can negotiate prices, whether it's prices of drugs or prices that you pay providers. So health insurance helps us with each of those three functions. So that's why we think of it as an option for financing TB and HIV. Many countries across sub-Saharan Africa and Southeast Asia are really putting a lot of focus on health insurance as one of the ways that they can achieve universal health coverage. But just a quick note, it is only one way of achieving each of these things. So why use health insurance for TB? Like I mentioned earlier, TB programs heavily donor financed. And so is the HIV program. In addition to which, there's a long way to go in both programs to reach substantial control, whether it's control of HIV or TB. So we need to massively increase the uptake of services. But there's also people who will tell you no, that health insurance is not the way to go. And the reason for that is quite logical. In Nigeria, for example, there's a little bit of tension between the states who want to include TB and HIV in their benefit package that their insurance schemes will cover, and the federal level, because the federal government says, well, the TB program is free, so we don't need to include it in the health insurance benefit package. It is free, but it's also not free. So if you think of TB services not as just TB services, but as the individual services, and I don't have a reference here, I apologize. I believe this diagram is sort of based on a Philippines Health Insurance Agency, the PhilHealth diagram. But if you think of the TB services and you break them up, different people are paying for them, right? So if it's immunization, it's part of the immunization program. If there's a free program for treatment, then that free program might be paying for screening at facilities that are in that free TB program, might be paying for treatment for drug-resistant TB and in hospital admissions. So all well and good. But here's the thing. So in 2013, a group led by Kingsley Ukwaja in another state in Nigeria did an analysis on costs to patients. And the average direct cost to a patient for the pre-diagnosis was $49 per patient. The average treatment cost was $36 per patient. But the indirect costs that occur before they enter the program is $400. In a country where 60% of the population lives on less than $1 a day, and 80% lives on less than $2 a day, if you're incurring $416 before you get into the free TB treatment program, that's the catastrophe. It's already happened. So the treatment program isn't going to help that. The catastrophe will continue to happen. And one of the things that we like about health insurance is that what that does is it removes some of the barriers that make that initial presentation for TB. It removes some of those barriers. If people are going in for ANC care, if people are going in for respiratory infections, if that becomes the norm because the barrier of accessing care, the financial barrier of accessing care has been removed, then maybe we can get people into TB and get TB diagnosed faster and quicker and avert some of those catastrophic costs. And at a national level, when we look at these costs, so that was a study in one state, but if we look at the costs at the national level, that bears us out. So in the National Health Accounts exercise, where we look at all the money that's spent on health and trace it through who spends it, where it's spent, what disease it's spent on, who benefits, we see that for TB, 70% of the cost of TB is borne by households. Of what's left, a lot is funded by various levels of the Nigerian government, but a lot is also funded by donors. So 15% by the government, 10% by donors. So there's a long way to go to meet any coverage targets for TB or HIV. And right now, a lot of people are paying for that out of pocket. So there's a couple of things to do if we want to get TB into the benefit package. One, we've got to show financial feasibility. There are people who will say, when you try to put it in a benefit package, what are you doing? I answer this question a lot. They say, the benefit package needs to be simple. We need it to cover ANC, childhood diseases, children under 5. We need to focus on the simple things. Why do you want to go and blow it up by adding HIV and TB to it? I've got an answer for that, and I'm coming to it. Then there's the technical feasibility. It's one thing to say that you're going to deliver it through the benefit package. It's a completely different thing to actually be able to do it. There's a lot of work around actually making it happen. Unfortunately for you, I'm not going to go into any of that in this presentation. So adding it to the benefit package, what does that mean? So an actuarial analysis is when we look at the population that's going to be covered, we look at the incidence of disease in that population, so the risk people have of falling sick, and then we look at the cost of actually covering all of the services that we want to deliver. And we estimate how much money each person needs to contribute to the pool in order for us to sustainably address all of the illnesses. And for the benefit package in Lagos State, it's $28 per capita per year. So what's the cost of adding HIV or TB to that benefit package? Every time, this is a large room, so I'm not going to go through the who thinks it's more than 20, who thinks it's more than 10, but I'm yet to have anybody even vaguely guess how much it's going to add. So I'm going to not keep you in suspense, I'm just going to tell you. So to add HIV, including art, to the benefit package would add 68 cents to that $28. Assuming 20% of the population has health insurance coverage in Lagos State. To add TB would cost just $1.60. And part of that $1.60 is because we've got drug-resistant TB in there. If we were to take drug-resistant TB out of the benefit package, that number would fall substantially. So basically what we're saying is, it's not going to blow up the benefit package. And this is very powerful information when we're talking to the Ministry of Economic Planning and the Ministry of Finance and politicians who might think that because these are such serious diseases and they're so expensive, that this will destroy the health insurance, the idea of health insurance. It doesn't. So that's all positive. But like I mentioned earlier, the delivery is a different kettle of fish altogether. When you have a vertical program, you choose where the support is going. When you have health insurance, they choose where they come and get the support. And there has to be trust in the system. If you're telling people TB is covered in the benefit package, they've got to actually be able to access TB care. It all falls apart if they go to places and then they can't get it. And the process of making it accessible is humongous. I'm a health economist, and I only recently took over managing a TB service delivery program, and I've got to say that I thought the mobilizing money for TB was difficult because I had to deal with politicians and ministries of finance and economics and modeling, etc. But the complexity of delivering TB through the private sector and through patent medicine vendors and community pharmacists and labs and private providers and public providers, my head just sort of went like I have newfound respect for people who work in TB service delivery. So in summary, putting TB in the benefit package and HIV in the benefit package, because we actually did HIV before we moved on to TB. They're both in the benefit package for Lagos State. And we learned a lot of lessons from the process of doing it for HIV that we then applied to TB. But sort of in summary, neither TB or HIV are going to blow up the benefit package, even if you don't cover everyone immediately with the health insurance. Free programs are not protecting people from catastrophic expenditures. So it is not simply a case of we have a free program, we don't need to put TB or HIV in the benefit package. But there's a but. As somebody said earlier, it's not a magic bullet. It's a lot of work to make sure the actual delivery can happen, because you're now talking about private providers and public providers, many of whom you don't have the same kind of control over when you have a vertical TB program. It doesn't eliminate the need for direct financing. We still have to do behavior change. There's still many things that need to be done on a TB program that can't be paid for through health insurance. And lastly, and perhaps this is the one that's, I think, the more powerful argument against, it's a long process, it's a slow process to put in place a health insurance program. So we're going to need direct funding for TB for many years, even with health insurance. Though it's a great idea for long-run sustainability, growth is slow. Many sub-Saharan African and Southeast Asians are putting in health insurance programs, but it's going to be a long time before that coverage reaches the kind of levels that we'd like to see in order to achieve the ambitions and objectives that we've got for HIV and TB. So thank you so much for your time, and some of my collaborators are up there as well.